say goodbye to monotonous books, and say hello to colorful, interconnected mind maps. In this series, we will quickly help you revise important concepts with the help of mind maps, which you can access later using our app. In this video, we will talk about various types of osteomyelitis and periapical pathologies. First type is acute separative osteomyelitis, which is typically a polymicrobial infection caused by bacteria, such as Staphylococcus aureus, Staphylococcus albus, Streptococci, anaerobes like bacteroids, Porphyromonas, or Prevotella. The clinical presentation may vary depending on the affected bone, but some common features include: in the maxilla, the infection is well localized. In the mandible, it is diffuse and widespread. Adults may experience severe pain, trismus, paresthesia of the lips if the mandible is involved. Lymphadenopathy and fever may be present. Affected teeth may become mobile and pus exudation may be seen from the gingival margin. Swelling or redness may not be evident until periosteitis develops. In the early stages, that is, 1 to 2 weeks, there may be no radiographic evidence. Later on, individual trabeculae in the bone may become fuzzy, indistinct, and radiolucent areas may appear. Histological examination shows the medullary space filled with inflammatory exudate, primarily polymorphonuclear leukocytes, occasionally with lymphocytes and plasma cells. Osteoblasts bordering trabeculae may be destroyed, leading to necrosis and resorption of bone at later stages. The standard treatment for acute separative osteomyelitis involves debridement, drainage of abscesses, and administration of appropriate antimicrobial therapy to target the specific bacterial pathogens. The next type, chronic osteomyelitis, has different forms such as chronic separative osteomyelitis, chronic focal sclerosing osteomyelitis, chronic diffuse sclerosing osteomyelitis, and Gary's osteomyelitis. We'll discuss in detail about two of them. Chronic focal sclerosing osteomyelitis, also known as condensing osteitis, is caused by a mild bacterial infection that enters the bone through a carious tooth. It commonly occurs in individuals who have a high degree of tissue resistance. This condition is most commonly observed in children and young adults. The mandibular first molars are the teeth most frequently involved. Patients may experience mild pain. Radiographically, the lesions appear as a well-circumscribed radio-opaque mass of sclerosing bone. The lamina dura remains intact, and there may be widening of the periodontal ligament space. The border of the lesion can appear smooth and distinct or blend into the surrounding bone. Chronic focal sclerosing osteomyelitis can be differentiated from other conditions like cemento-osseous dysplasia and benign cementoblastoma. Histologically, the lesion exhibits a dense mass of bony trabeculae with little interstitial marrow tissue. If present, the marrow may be fibrotic and infiltrated by lymphocytes. The trabeculae show multiple reversal and resting lines, giving a pagetoid appearance. The osteocytic lacunae are empty. Chronic focal sclerosing osteomyelitis can be distinguished from idiopathic osteosclerosis based on its histological features. The treatment approach for chronic focal sclerosing osteomyelitis involves managing the associated teeth. Root canal treatment or extraction may be indicated. Surgical removal of the lesion is not typically necessary unless it becomes symptomatic. The next lesion is Gary's chronic non-separative sclerosing osteitis, also known as periosteitis ossificans, is a type of chronic osteomyelitis characterized by a proliferative periosteitis. Gary's osteomyelitis often presents radiographically with a carious tooth opposite a hard bony mass. There is a focal overgrowth of bone on the outer surface of the cortex, leading to a duplication of the cortical layer of bone. It leads to formation of a thin but definite cortical bone. Histologically, Gary's osteomyelitis exhibits a supracortical subperiosteal mass composed of reactive new bone and osteoid tissue. Osteoblasts border many of the trabeculae. The trabeculae are oriented perpendicular to the cortex and are arranged parallel to each other or in a retiform pattern. The connective tissue is fibrous and may show a diffuse or patchy presence of lymphocytes and plasma cells. Gary's osteomyelitis should be differentiated from other conditions such as hypervitaminosis, Ewing sarcoma, metastatic neuroblastoma, syphilis, and leukemia. The treatment approach for Gary's osteomyelitis involves addressing the associated teeth. This may include endodontic treatment or extraction of the affected teeth. In most cases, surgical intervention is not necessary. Some important points on chronic suppurative osteomyelitis and chronic diffuse sclerosing osteomyelitis are given in this section of the mind map and can be noted down from here. The next periapical disorder we see is apical periodontitis, which can be acute or chronic. Acute apical periodontitis is an inflammatory condition that occurs in the periodontal tissues. Its clinical features include constant throbbing pain in the affected tooth area. The affected tooth may feel slightly elevated in the socket. Tenderness on percussion of the tooth is positive. Vitality test is negative or shows a delayed positive response, indicating that the tooth nerve is affected. Other clinical findings are typically normal except for slight widening of the periodontal ligament space around the affected tooth. Radiographically, there may be a slight widening of the PDL space surrounding the tooth root. Histologically, there are signs of inflammation in the PDL. Vascular dilation is observed in the affected area along with polymorphonucleoleucocyte infiltration. Initially, these inflammatory changes are confined to the root apex as this area is richly vascular. It is associated with bacterial infection. It can lead to periapical abscess. The treatment and prognosis of acute apical periodontitis depends on the cause. Possible treatment options include selective occlusal grinding may be performed to alleviate the trauma, and if the condition is associated with bacterial infection, then root canal treatment or extraction of the affected tooth may be necessary. The other one is chronic apical periodontitis or periapical granuloma. It is a localized mass of granulation tissue that forms in response to an infection in the root apex of a tooth. However, it's important to note that there is no true granulomatous inflammation seen microscopically. Its clinical features include the involved tooth is non-vital. Patients are usually asymptomatic, but mild pain may be present while biting. The affected tooth may feel slightly elongated in the socket. On clinical examination, the tooth may be slightly tender on percussion with a dull sound. The earliest radiographic sign is widening of the periodontal ligament space around the tooth root. Proliferation of the granuloma leads to resorption of bone, resulting in a radiolucent area at the periapical region less than 2 mm in size. The radiolucency may be well-defined or ill-defined. Loss of the apical lamina dura may be observed, and root resorption is a common feature in periapical granulomas. Microscopic examination shows inflamed granulation tissue surrounded by a fibrous connective tissue wall. Granulomatous tissue predominantly contains macrophages, lymphocytes, and plasma cells, with occasional mast cells and eosinophils. Russell bodies and pyronin bodies may be seen. Epithelial rests of malases, which are remnants of Hertwig's epithelial root sheath, may be identified. Cholesterol crystals, red blood cell extravasation with hemosiderin pigmentation, and small foci of acute inflammation with focal abscess formation can be observed. The management of periapical granuloma involves either extraction of the affected tooth or endodontic treatment to remove the source of infection and promote healing. The last category, periapical abscess, include acute periapical abscess and chronic periapical abscess. Is a separative process that occurs in the dental periapical region. Taking a look at them quickly. Acute periapical abscess involves severe tenderness of the affected tooth. Pain is relieved by applying pressure. Regional lymphadenitis and fever may be present. Rapid extension of the infection to adjacent bone marrow can lead to osteomyelitis. Widening of the periodontal ligament space may be seen radiographically. The abscess may not always be clearly evident on radiographs. Clinical features of chronic periapical abscess are that it is often asymptomatic with no symptoms. There is a mild, well-circumscribed area of suppuration with little tendency to spread from the local area. An ill-defined radiolucency is observed at the periapical region on radiographs. Histologically, the central areas show disintegrating polymorphonucleoleucocytes surrounded by viable leukocytes. Dilation of blood vessels in the periodontal ligament and adjacent marrow space is seen. The marrow space also exhibits an inflammatory cell infiltrate. There may be serous exudate on the tissue surrounding the suppuration. The treatment for periapical abscess involves drainage of the abscess. This can be achieved by either opening the pulp chamber or extracting the affected tooth. Root canal treatment is an effective treatment to address the source of infection and promote healing. If left untreated, a periapical abscess can lead to complications such as osteomyelitis, cellulitis, bacteremia, and the formation of a fistulous tract that opens on the skin or oral mucosa. With this, we have come to the end of this video discussion. Hopefully, we have helped you revise this topic quickly. Now you can head over to the MCQ section of our app for solving some questions. Happy learning!